Dr. Galvin is professor of neurology, psychiatry, nursing, nutrition, and population health at New York University Langone School of Medicine. He serves as director of the Pearl I. Barlow Center for Memory Evaluation and Treatment, Lewy Body Dementia Program, NYU Alzheimer's Disease Assistance Center, and as associate director of the NIA-funded Alzheimer's Disease Center, leading both the clinical and educational course. Dr. Galvin received his Bachelor of Arts degree in chemistry from New York University in 1986, his Master's of Science in Nutrition from Rutgers University in 1988, his MD from the University of Medicine and Dentistry of New Jersey in 1992, and his Master's of Public Health from St. Louis University in 2004. He has authored over 130 scientific publications covering basic, clinical, and translational science in the areas of neurodegenerative disorders, dementia, and cognitive aging, is the editor of 3 textbooks on dementia, and leads numerous clinical trials investigating new therapeutics on Alzheimer's disease and related disorders. Dr. Galvin's research has been funded by the National Institute of Health, Centers for Disease Control, Michael J. Fox Foundation, American Federation for Aging Research, Alzheimer's Association, New York State Department of Health, Alzheimer's Drug Discovery Foundation, and the Morris and Alma Shapiro Fund. Wow. So you're in for a treat. Enjoy.
Can everybody hear me okay? Yeah. Usually people tell me to be more quiet, so there shouldn't be an issue. All right, so it's my pleasure. Well, first I'd like to thank the organizers of the meeting for having me come down and visit. It's really my pleasure to speak with you this morning about a topic that's near and dear to my heart, which is Lewy body dementias. So there's 2 screens, and on occasion I'll point, but I'll point to both screens. So and it'll be a bright green dot. So if you're looking at this screen and you don't see a dot, it'll come there, so you don't have to whip your head back and forth. So first, I just want to acknowledge all the people that really do all the work. So I get to travel and do the talks, but these are the people who actually do all the work. So they're people from my lab and collaborators from multiple other universities. So I want to build a story for you in the next 6 or 7 hours. And so what I'd like to do is begin talking about a disease for which we actually know a lot about. And this serves as a template for how we can study some of the problems that we're seeing, and that's Parkinson's disease. So Parkinson's disease has been described for well over 200 years as a clinical diagnosis, but the syndrome was known for many years before that. And so these are the criteria that were considered for Parkinson's up until very recent times. And so for Parkinson's disease, you needed a movement change, so slowness in movement, that's bradykinesia, means slow movement, stiffness, a tremor, and trouble with balance. But one of the important things was there were early exclusion criteria. In other words, if you had some of these symptoms, you couldn't possibly have Parkinson's disease, and I bolded one of them, which is early dementia. Early dementia. And so for a long time, we thought that Parkinson's actually had no problems with their cognition. And in fact, from a historical perspective, James Parkinson, who described the disease in the essay on the shaking palsy in 1817, said that the senses and intellect were unaffected. What's interesting is Dr. Parkinson actually described the book in 5 people, but only examined 2 of them. The other 3 people he saw walking down the street. That's a true story. Really, the first time anybody described any changes in cognition was in 1888, and that was Charcot, who was a famous psychiatrist, and he described changes in cognition and personality. And then a very famous textbook by Lord Brain back in the 1930s, and this was like the standard textbook on neurology for 50 years, said that Parkinsonism is not accompanied by any change in their mental abilities. Rather, their intellectual capacity is masked behind their movement disorder. So they didn't have a problem with their memory, they just couldn't express themselves. So it wasn't really until recently we began to understand some of the changes. And so now we have new criteria for Parkinson's disease dementia, and this has to occur in the context of established Parkinson's disease, so at least 2 years after all the motor symptoms began. And they can have changes in any of the different cognitive domains. So we have some bedside tests that are supposed to help us make a diagnosis, but still, in fact, it is a little challenging to make a diagnosis of Parkinson's dementia. Now, Parkinson's dementia is one type of Lewy body dementia. The other type of Lewy body dementia is a much bigger challenge, and that's dementia with Lewy bodies. Okay. So this is a disorder that often begins as a collection of symptoms and is very, very difficult to diagnose. So what you have are some core features that you have a problem with memory and thinking, and then you have some changes in levels of alertness and attention. Those are called fluctuating cognition. I'm going to talk more about that in a little bit. Visual hallucinations, seeing things that aren't there, and various amounts of Parkinsonism. And so while we have criteria that are very specific, they're not very sensitive. What that means is if you make a diagnosis of Lewy body dementia, you're probably going to be right. But the chances of an average physician making the diagnosis is pretty small. And so there's a tremendous delay in making the diagnoses. Okay? So we had done a survey of almost 1,000 caregivers to try to find out the diagnostic experience. And it took the average patient 18 months, visiting 6 doctors over 12 visits to establish a diagnosis. And many times the diagnoses initially were wrong. Okay? And so if you get a wrong diagnosis, then you can be exposed to lots of potential problems. So the focus of the next part of the talk is really going to be on some of the work that we've been doing to try to improve the ability to understand the disease and improve the diagnosis. So these are pictures of Lewy bodies. Lewy bodies are intracellular inclusions, clumps of protein. You cannot see them on a scan. You can only see them at autopsy material under a microscope. So there's no way to visualize this in life at the present time. Many people are working on it, but at the present time, it's only a post-mortem finding. Okay? And so this is a nigral neuron, the neuron that makes dopamine in the brain. And that arrow is pointing to that little pink body right there. That's a Lewy body. And so that was described in 1912 by Dr. Lewy in the brains of people with Parkinson's disease. Right underneath it is a cortical Lewy body. So a cortical Lewy body. And so these were described in 1961 by Dr. Okazaki. So almost a 50-year gap. So we understood the pathology of Parkinson's disease in the early 1900s. We didn't understand the pathology of Lewy body dementia until almost 50 years later. Okay. Now we're much better at it because we have better tools. So right next to both panels are antibody stains, and so we can see these Lewy bodies a lot better. So it's not that Lewy bodies are an epidemic at this point, it's just that we're much better at picking them up at autopsy. We're still not very good at picking them up in living people, though, and that's part of the problem.